Okay, we are.
And we
Good
go.
evening, everyone. Today's
On.
session is going to be really helpful and it's led by Dr. Rashmi Nayak and Dr. Madhusudan C from Apollo Cradle and Children's Hospital. They are going to talk about myths surrounding regional anesthesia in obstetrics and labor. So stick around until the end and ask us questions if you have any. Let's not keep you waiting any longer. Doctor, you have the stage.
Thank you. Okay, a very
Good
good
evening.
evening. Yeah, very
Good
good
evening.
evening to everyone, whoever is watching this live stream right now. Let me introduce myself. I'm Dr. Rashmi Nayak, Senior Obstetrician Gynecologist, a fertility specialist, and a laparoscopic surgeon by profession. And along with me, this is Dr. Madhusudan, who is a senior anesthetist from Apollo Cradle Hospital, Rajaji Nagar branch, and he has more than 39 years of experience in this field of anesthesia. And welcome everyone. Today is actually a topic discussion, and it's exactly not a health talk, basically. Why did I choose this topic? Is that there is a lot of myth surrounding the anesthesia or the analgesia part related to labor and obstetrics. Most of the time, whenever an antenatal or a pregnant couple who enters the clinic has this quite common questions which I'll end up answering most of the time. So I decided, why not hear from the expert itself today? So this is going to be more like an interview wherein I'm going to ask the same questions which my patients put across to me in my clinic OPD, and how do I answer probably will might differ a little bit from the anesthetist itself. So let's start with the very first question, because most of the patients are very anxious, apprehensive when it comes to taking analgesia in labor. They have a lot of doubts around it, and they have a lot of myths surrounding it, which needs to be clear so that they are confident when they come and approach a hospital and the doctors. So coming to the questions, sir,
Yeah.
let me just start with the first question, which is the most common question we ask. What is actually meant by a labor anesthesia or analgesia?
Labor anesthesia, analgesia, both are same. This is a method in which a patient is rendered painless. Once the labor process starts around, let's say around 2 centimeters or 4 centimeters with salutation of the cervix, till the delivery of the patient, she should not feel any pain.
Yeah.
That is the motto behind this epidural anesthesia, epidural labor analgesia.
Yeah. So I think sir appropriately answered already that everybody asks this question: what is meant by painless labor, wherein a patient goes through the labor process without undergoing the pain associated with it.
Absolutely.
So next important question most of the patients ask is, apart from epidural, what we give to the back, it's a small spinal needle which goes in, and wherein the catheter remains there, a tiny small catheter. And patient asked me, is there any other option or varieties of anesthesia associated with labor? Could I opt for that?
Yeah.
What will be your take on this?
Yeah. Epidural anesthesia is just not new. It's been practiced since the beginning. And they have some non-pharmacological methods like massage and music therapy, then some aromatherapy, then later on they'll go into some TENS,
TENS, yeah.
TENS,
Which is the
the
latest.
trans-electrical nerve stimulation of the back, so that the fibers are blocked and then the patient feels less pain during the labor. And then the warm water therapy. There's a hydrotherapy. Patient is made to sit in a warm tub of water so that the pelvis is submerged up to abdomen, so that the patient feels subjectively better.
Yes.
And the pain also is a bit less, but it's not abolished.
Yes.
So, and there are certain drugs like, we have like some inhalation anesthetics in a low dose. They have tried Trilene and chloroform in the past, halothane. These are tried, but they have some side effects. But out of that, one which stands in a better sense is nitrous oxide. It's a combination of nitrous oxide and oxygen, or nitrous oxide in the air. It's called Antonox.
Yeah.
It's around 60-40 mixture of the oxygen and nitrous oxide. So it comes up on the cylinder. You can switch on cylinder and put the mask.
Push the mask.
Yeah, put the mask. It's an indication that as soon as the patient gets the pain, you just switch on that. As soon as immediately the nitrous oxide flows through this one, and then you get within 3 or 4 breaths, you get analgesia.
Correct.
It's only analgesia.
Yes.
I'm telling you, it's not. It can give up to 60%, 70% of the pain relief.
Correct.
And once the pain goes up, then you can automatically switch off.
Yes.
So like that, some people are excited. That's the only popular method. Entonox, that's the only used. But if you want a perfect 100% painless anesthesia, you will have to switch over to epidural. It's a process by which is a small catheter, around 18 French or 6, 8, 20 French, is passed through a small epidural 2E needle in the back, in between the two spines, usually lumbar space. And then that's epidural catheter is passed through that. We identify the epidural space by our own methods, by experience we'll gain it. And then once we know that the catheter is in the epidural space, then we give a test dose of xylitol and adrenaline. Then if the test dose says absolutely fine, then we give a full dose, normally around 10 ml of 0.2% ropin, something like that. Then we push that and then we induce or we inject the drug so that the epidural starts acting like that. So this ultimate is epidural anesthesia, I tell you. Epidural labor anesthesia.
So I would like to add maybe a couple of points here. So whenever a patient asks me what are the pain relief options they have during labor, there are IV painkillers where we call as IV NSAIDs, which can be given, but again the pain relief is less than 50% in those, and it has to be given intermittently. And there are a few drugs which, when we give to the mother, might suppress the baby. Means the respiratory system of the baby might go into suppression. Then we could have, we might have a baby going into an ICU because of breathing difficulties or breathing complications immediately post delivery. So we do not recommend them during labor. Coming to the mask, which Sir said or spoke about, the Entonox, we commonly call it as a laughing gas therapy. Yes, but again, these are the ones which has to be given intermittently. We cannot keep it like a continuous process, whereas in epidural, what happens is, it's a continuous pain relief process wherein a patient do not feel the pain right from her tummy up to her lower limbs. And most of the time, I think the blockage which the anesthetist gives is almost close to 90%. 80 to 90%, but only 10% is left so that the patient is able to urinate, that is pass urine, and able to feel the pain during your second stage of labor when a patient is told to push the baby. I mean, these efforts, the secondary maternal efforts which a woman in labor has to do, can be given only when the pain is taken out a little bit. So that's why we do not give 100% pain coverage, but yes, almost you can say 90% and above. So coming to the next important questions, are there any prerequisites which needs to be fulfilled before going in for an epidural anesthesia?
For that matter, epidural anesthesia can be taken by any individual. Any labor patient who wants to have a painless labor, she has a right to take epidural anesthesia.
Yeah.
Everything is, you should have an experienced team behind and staff behind to look after that. If you are, prerequisites is that you should be having a team of anesthetists and staff nurses so that they can carry out the other procedure like that, in that.
No, what I meant is a consent required before the procedure.
As like any other procedure,
yes,
a consent is required, and then the whole process is explained to them. Because it's a labor is such a severe pain.
Yes.
Labor is a very severe pain. So this is a process by which epidural anesthesia will take away the most of 90% of the.
So next important question which my patients ask is, what are the commonest complications or maybe the rarest complications or side effects which are associated when you take an epidural anesthesia to your back? So what would be your answer?
Nowadays it's become very fad, whenever they come to doctor, they talk about the side effects.
Side effects first, then the effect.
They eat anything outside and then get away with it. But when I come to a doctor, is it have side effects like?
Yes.
No, definitely. Any other procedure, this epidural is also. It's quite a. It does have some side effects, and especially first backache. You may have some backache for few days.
Yes.
And then they may have headache in case it is a dural puncture.
Yeah.
Otherwise, and there is a next infection is some such infection. Some subdural infection. And during the process, if there is any hematoma, when you injure a vessel, then it's called subdural or epidural hematoma. That's also one of the things which can, it can grow in size and then it can cause a paralysis or something like that. These are the minor symptoms, as per se, and sometimes shearing of the epidural catheter is not administered properly. If the process is not administered, you will have shearing of the catheter. That catheter may be cut. So these are some complications are known, but per se, we on an average, we don't see any much of the complications in this local practice.
Thank you so much, sir. But I would like to share one of the anecdotal case at this junction because I had a patient when we tried giving her an epidural labor analgesia. It inadvertently, I think maybe because of something, it entered the spinal space, and then instead of epidural, it reached the spinal area,
Okay.
and then it became a high spinal, and the patient, she could not really breathe, and then there was a drop in the baby's heartbeat, so we had to take her up immediately for a section, which just happened in less than 20 minutes. So I feel these are the very rarest of the rarest
No,
complications
these
which we
things
have
don't
come
happen
across.
in experience.
Yes, no, it doesn't happen
This
in
dural tap is
experience.
one of the
Yes.
most complications because between the dura and the epidural space, when the dura and the epidural hardly 0.5 millimeters.
Correct.
So if you are little 1 or 2 millimeters go ahead, then you may hit the tap, hit the dura, and then you get a spinal tap.
Fortunately,
But-
the patient was a doctor, so she could understand the complication of it. And I would say these are very rarest of the rarest possibilities which happen. I think that is why it is all the more very important that the patient should opt for it in a good setup where there is a senior anesthetist involved and a senior doctors involved, and where there is emergency facilities. Important question here to be underlined is emergency facilities available for an
Resuscitative
emergency
measures.
cesarean, yes, and the
Resuscitative measures
resuscitative
should be there,
measures to be available.
Yeah.
So because any procedure for that matter, even a small biopsy taking can turn out into a complicated scenario. We do not know, but when we have to explain all these things to the procedure patients. And coming, I think you've already answered me this question, sir. I wanted to ask you, the commonest question they ask is post-procedure, what are the complications I'm going to face, doctor? I mean, will there be any allergies associated with the injections or medicines they are going to use?
Allergies is as usual, for a local anesthetic, we test in before only whether the patient is allergic to Cesarean and Cesarean, whatever the ropin, whatever is we using. They are almost 99.9%. They are not allergic at all.
Mhm.
So that can be that one thing. Yeah.
And is the procedure itself painful? First question they ask me is, when I take a pin or a needle to my back, is the procedure going to be
No,
painful?
it's relatively very painless because we give a local anesthesia just before we pass to his needle. To his needle is quite big, I suppose. But for that to have anesthesia, then from skin to the dura is almost anesthetized. Beforehand, only we give 5cc of 2% Zolacan, and that area is totally numb. When I pass a catheter, patient won't feel except for the little pressure. When I pass the needle, you will feel little lighter pressure, but absolutely painless, definitely.
So here also I would like to share my own experience. I think I've undergone 2 cesareans, so I know how an epidural. I've taken epidural myself. So I know how it is. It's not a painful procedure. It's a very smooth procedure, in fact, done in the expert hands. And coming to the next important question. Most commonly, patients ask me, suppose I take a spinal anesthesia or an epidural anesthesia now, and then I land up in a cesarean. Can that be done with the same anesthesia? So we generally advise them or tell them that in case during the process of labor, we come up with a situation where there is a need of an emergency cesarean, we might have to do. It can be conducted with the same port, so patient need not have to again get pricked one more time.
Yeah, epidural has an advantage. Because there is a catheter inside, that's a boon for us.
Yes.
So we are hardly giving 0.125%, 0.125% of Cesarean. That is bupivacaine. Whereas a normal dose is 0.5%.
Correct.
So there's enormous. That means 5 times dilution we are giving. So that should not cause any problem. Epidural. That's the idea.
Right.
But if the patient, in case there is a fetal distress or a maternal indications where you need to deliver a patient very fast. So what happens is we can charge the epidural and same with our 10 to 15 ml of 2% logs along with the fentanyl of 50 max. So that will within 5 minutes it will act. So it will be total epidural anesthesia. So that we can conduct LSCS very easily.
Yes. So this is an added advantage to the patient.
And it also gives, in case if you want post-operative anesthesia, also you can be continued through that.
Yes.
Suppose the patient has gone through surgery and post-operatively with the through
That
epidural.
was my next question.
Epidural.
Yes.
Also, I'll
Right.
look at that
No
question.
problem.
So epidural through the epidural catheter only we can give fentanyl.
Yes.
And a low dose of Cesarean 0.01%, around 5 ml, another 50 max of fentanyl, diluted up to 10 to 12 ml. So make it a solution and give it every 4 to 6 hourly.
Right.
So for post-operative day 1 and day 2 we can give, and as and when the patient becomes normal, then we can take out the catheter. So patient will be off the epidural and off the drugs. So the post-operative period will be wonderful.
Yeah. So how long can we keep this catheter? Is the next question.
So we can keep post-operative. 3 to 5 days is the recommended dose. Recommended
We
period,
can-
period where you
maximum.
can keep the epidural catheter.
Yes.
Because after a bit, if you extend, then there will be chance of infections. So better to use it. Better take it out before 3 to 5 days.
Herein, I would like to ask one more question. Like, suppose we want to give blood thinning agents to few patients who are at risk. Like, suppose I want to give a heparin or an ecosprin to a patient post-operatively. So, epidural is again a contraindication.
Yeah,
We cannot keep it. So,
Yeah.
when do we remove the epidural? In
Yeah,
such
normally
patients?
with anticoagulants, whatever the form, whether it's Sprin or dipyridamole or this one, whatever the short-acting your blood thinners.
Yes.
So there should be a sufficient gap of 12 hours.
Yeah. Okay.
12 hours.
Yeah. So next
Minimum
again,
12 hours, you are not supposed to give the drug, or if the drug is given, then we have to wait for 12
wait for
hours.
12 hours. Yes.
So you have to stop the drug before taking epidural.
Yes. So next question the patient asks is, suppose the epidural catheter is removed. Now post delivery, suppose a patient goes through a normal delivery while on epidural, or a patient goes through a cesarean while on epidural. In both the scenarios, suppose we remove the epidural immediately post the procedure, post the delivery. How long will there be the numbness in the lower limbs, or how long
Normally,
can it exist?
yeah. Now I got your point. So normally this sensor can act for about 2 hours.
Yes.
So if I had given the last dose, exactly find out the time. Exactly around 1.5 to 2 hours it will act. So even if you remove the catheter, that's not important. But what is important is when you injected the drug. You note that time. Every time we inject, we note the time. So exactly after 2 hours, patient will have absolutely no sensory or motor
So
disturbances.
how early can a patient get up from the bed and go past urine?
Yeah,
Or be
I
ambulate,
would
or
give
can
around
they ambulate
2 to 3 hours.
themselves?
Fairly
2 to
good.
3
Fairly
hours.
good. Yeah.
Okay.
Test for motor movements, then sensations. Then we can, with the support, of course. First time you need some support to go to loop, and then once they are confident, then you can lead them.
And the very most important question, and the most commonest questions asked by all the patients is, when I undergo an anesthesia, whether it is spinal or an epidural, wherein a needle is put in my back, on a long-term basis, suppose after over a period of 8-10 years, will I experience chronic low back pain or chronic low pelvic pain? Will it be a complication associated with the procedure? These are the commonest questions asked by all the ladies. So,
No,
what do you have to say on this?
No, absolutely, nothing of the sort. No backache, nothing observed, and then backache, if at all, it's there for about only few days. And once the patient resumes her activities, normal activities, then the patient pain goes up. And whatever if it remains, it may be in your mind because of the labor, as per se, because of the labor, because of the delivery, because of the pregnancy, the ligaments are stretched. The whole joint and the systems are in a different shape. There is lumbar lordosis. Because of that, they get the weak. They get the backache, and most of them, when they attribute to they blame us.
They blame the anesthesia, which is not true.
Yeah.
So kindly note, anesthesia do not have any
It does not.
long-term complications to any of the patients. So next important question, if there is a patient who is having a history of disc prolapse or a chronic back problem, or undergone previously a spinal surgery on her back due to some other reason, or she has a history of Cox tuberculosis, what you said, spot spine previously, and has been treated, and now she comes during labor or any other surgical procedure, can we give spinal or a regional anesthesia for such patients?
Definitely, it is not a contraindication. We look into examine the patient and we assess where exactly the surgery took place.
Yes.
Whether the L5S1 disc, L4-5 disc, or which disc was involved, and then we'll see what exactly that done. That procedure they have done.
Okay.
So we choose a space higher, maybe L1 or L2 or L2 or L3 we choose. Through that we can pass a catheter and safely conduct our labor anesthesia. That's what is not important.
So associated with this question, I think it was just an attachment to this question. Is there any absolute contraindication when it comes to giving regional anesthesia in any patient in your practice?
Yeah, there are certain conditions, such as one is, first of all, thing is the patient refuses.
That's a refusal itself. Yes.
Another thing is if the patient is on anticoagulants for some time because of cardiac problems, then you cannot do epidural anesthesia. And if there is a local infection in the spine, back if there is an tinea or some boils, something that is that is noticed, then it will give rise to infection to
Yeah.
the meninges or something.
Yeah.
So barring these three,
Mhm.
I don't think any labor patient can take epidural anesthesia.
And this question was asked by one of my patients just yesterday. She said, if I've undergone a spinal in my last delivery and undergone a cesarean, will it be safe to do the same space again for the next cesarean?
Yeah,
I
absolutely,
think
no
it's
reason, because it takes hardly 5 days to heal.
yeah.
So literally after 1 week, you can do a procedure. Anything is possible.
So, coming to, would you recommend any back exercises for such patients post procedure?
Yeah,
And if it
definitely.
is,
Definitely, or you get to get in touch with a physiotherapist.
Mhm.
Probably they will tell you or some back exercises like pose in a prone position, lift your head 10 to 20 times, then lift your head legs 10 to 20 times, and head and leg both raising.
Yeah.
So these three core exercises, and forward bending, and then especially head and neck, two positions. These two exercises, if you are doing regularly, then the back pain
back
goes
pain
away.
goes away. And another important question, because there's a lot of myth post delivery. Many people in their houses, they curtail intake of liquids or water to the parturient, means the woman who's just delivered. They do not give them liquids to take. They say, don't drink water, you'll bloat. Don't drink water, your body is going to bloat. So that's the commonest words they use. But these are few patients who have this headaches post
His
procedures.
headache is
So
get it.
yes, so these are the patients where we will tell them, hydrate yourself, try to increase the fluids. So what is your take on this kind
This
of
doesn't apply to
situation?
epidural. What I feel is epidural is relatively, because it's away from the spinal, there is no
Correct.
loss of CSF.
Correct.
So we cannot attribute anything for that.
So if
If there is a dural puncture, or there is spinal anesthesia for anything, suppose for other apart from epidural.
Mhm.
If you have taken spinal anesthesia for cesarean section,
Correct.
hysterectomy, and other things,
Yeah.
then usually in 3 to 5 days there is a small leak.
Correct.
Because we have punctured a dura,
Mhm.
and through the dura, you will find the CSF slowly leaks out.
Correct.
In a span of around 2 to 3 days, the lost volume is quite sufficient,
Mhm.
so that causes dragging of the nerves on the cranial nerves.
Yes.
Cranial nerves pain you will have,
Yes.
and you'll patient develop headache.
Headache.
Especially this is very characteristic when the
Ah.
patient lies down,
Mhm.
absolutely no pain.
No pain. When they get up,
When they
stand
get up, cough,
Yes.
they go to the bathroom, they get a throbbing headache.
throbbing headache. Yes.
It's only one particular symptom we concentrate on the patient. So
Yes.
we'll definitely diagnose as a PDPH.
Yeah. So as
It
otherwise,
is,
yes. So as otherwise also, that's what I'm trying to recommend, that a patient, if they have undergone a cesarean and delivered recently and have this headache, kindly increase your liquid intake, because this is the most
Yeah.
important.
Normally it takes around 3 to 5 days to heal
Yes.
that hole to be closed. So till then, whatever the loss is there, so you have to replenish that loss by giving extra oral fluids, or if the patient is on IV fluid and totally for 3 days you can give to 1 liter of Ricorlatate, and then be done with it.
It's
With
done.
some analgesics and relaxants, they should be fine. And in case if the patient, for after spinal I'm talking, not the epidural, if the patient has a BDPH symptoms and will be very severe to considering herself to be a bedridden,
Mhm.
then we think of giving an epidural blood patch.
Mhm.
It's again a small procedure, done it local.
Mhm.
So what we do is just select the space, one space above, one space below, and then take autologous blood.
Mhm.
We get into the epidural space, and then we collect 20 ml of blood,
Mhm.
and then slowly we inject.
Mhm.
So by injecting 20 ml, what happens is it forms a patch.
Mhm.
When blood clots, it becomes a hard substance. So it immediately seals up that hole.
Correct.
So you get a relief immediately.
Immediately.
This is what we recommend, the epidural blood patch.
Mhm.
This is advised.
Okay.
If severe PDPH, we can go for this epidural blood patch.
So I think one more important last question, that is in terms of your clinical expertise or experience in so many years, if there are any unusual situations which have arisen, like suppose we did an emergency and there a delivery or even any other surgical procedure a patient has undergone normally, and following that procedure immediately maybe patient is again landing up in any other emergency situation which again requires a surgery. So the commonest question they ask is, how many times can I take anesthesia? And is there any inter-delivery interval to be maintained between two procedures, two surgical procedures? Or I can go back-to-back anesthesia whenever there is a situation which arises.
Yeah, normally.
So what is your answer on
So if
this?
there is an epidural catheter intact,
Mhm.
and post-delivery, if you find there is a PPH,
Mhm.
or if there is any and placental retrieval.
Mhm.
The placenta is if it is remained inside. So for that we can give through epidural only we can give a top up.
Correct.
We can charge the epidural around 10 to 15 ml of 0.5% Cesarean and then make total epidural anesthesia, by which you can carry out even hysterectomy, you can do it, or exploration, you can do it, and cervical suturing also you can do it. These are procedures can be done.
Yeah, during the complications.
Yeah, during the complications.
So, which we face.
Yeah.
So,
And one thing I want to stress is this epidural, this labor, one case, what happens is they will have a lot of stress, pain, and movements during the labor. They will have a lot of pain, movements. These things causes a rise in the catecholamines in the blood, along with glucose. So these causes a metabolic acidosis, and so these compromise with the fetal circulation.
correct.
So they totally constrict the uterine vessels and placental vessels. So the blood flow to the infant is reduced. So that's the reason why this stress has to be taken out from the partial patient.
Correct.
And epidural is the only one method where you can take out the stress completely and relieve the pain as well as take out the stress from the
Obstetrician
patient.
aspect.
So the patient is fine and the total correction will be there.
Correct.
Automatic blood flow to be increased to the baby, and then the mother also is comfortable. The stress levels are come down.
Family is
She will
comfortable.
sleep.
Yes.
She will sleep happily. In fact, she goes to sleep immediately. We'll see the patient. Patient is in a severe pain. Once we give an epidural, we must see the smile.
Yes.
Give a nice smile, and then they'll go to sleep.
Yeah.
That's all.
You just
After that, then next 2 hours, 4 hours till the delivery, patient is absolutely painless. This is what I would recommend to take an epidural. Most of the postural patients like that.
So coming to one more question, I think it's a self question. I think I'm going to answer it myself because whenever a patient opts for this kind of painless labor, I know patients are extremely happy. Family is very happy, especially the spouse or the husband, because he doesn't see his wife shouting, yelling, or screaming or suffering with pain. She's comfortable, happy, smiling, relaxed. What are the difficulties as an obstetrician we face during a labor or delivery when a patient is on epidural? So I would like to answer that because of the epidural, we do see a little longer incidence of, a prolonged labor, what we say, because the labor might go a little slow. It might not go as per any normal labor, which goes in a faster pace, wherein we put a chart called as a partogram or a partograph, wherein we monitor the patient, whether the patient is going in flow with the drugs and the medicines we are giving, or the labor process is continuing properly in time or not, because we do have a delivery cutoff interval before which we have to deliver the patient either by normal or by cesarean. So we do see increased incidence of prolonged labor taking a lot of time to happen. And also during the second stage of labor, what I mean is when the head is visible to the time of delivery of the baby. That is what we call as a second stage of labor, wherein we might have to use in a little bit of instruments to deliver the baby, as you might have seen in movies like Three Idiots, wherein they, but I would not like to recommend that as a main procedure because we do it in different setup. So there is an increased incidence of instrumental deliveries, we say, like vacuum or forceps. It's a possibility, but it's not necessary that it has to happen to every patient who goes through epidural. But yes, these are the things which we as doctors or obstetricians keep in mind whenever we give a patient to opt for such painless labor option. So I think with this, I would like to end my topic discussion. I think Sir was excellent in answering all the questions. I hope there's a lot of myths and doubts regarding painless labor is taken out of your mind. Here at Apollo Cradle, Rajajinagar, we recommend all the patients to consider this option of painless labor so that the labor process is smooth and they have a good, safe, and a good outcome. It's very safe, so kindly opt for it. And I'm sure you'll come with a positive response at the end of the delivery. Sir, do you have any questions to ask me? Because it's been me bombarding questions like a patient to you. So
no, obstetricians on their part during the antenatal checkup only they should give a hint about this, and then made them aware of this process existing.
Yes.
Because most of them are not aware. Yes. They are only bothered about the baby's development, your patient's conditions and things. On this point, you just touch upon this point, there is a possibility of taking an epidural anesthesia, and so that you will have painless labor. You give them in their mind, so that when the labor anesthesia starts, when the patient having a pain,
Pain, yeah.
when the patient get admitted for labor, they'll definitely ask for labor anesthesia. Then we can arrange for things.
Yes.
So this should come from the obstetricians also.
Yes.
Not only patients. Only few patients are been educated. They will know. But most of our Indian public, they're not aware of this process. So make it more popular by giving them a hint, so that or giving them. We have some placards so that they can in the OPD they can go through that.
Yes.
What is the epidural, how it is given, and what are the complications like. These charts are there. They can read up the chart and then make up their mind before coming to hospital.
Yeah, as an obstetrician, I make sure that every patient of mine is given these options quite early, maybe in their last 36, 37 term visit when they come to me. They have sufficient time to think about it, to read about it, to know about it before they land in labor or any other emergency situations.
Yeah.
So I think by educating the patients, by making them know what the procedure exactly is, I think half of our burden is taken out, and it becomes much easier for us to give the option to the patient when a patient walks into the hospital. We'll be very glad to take any comments or questions. If you have any on our website, you can.
We'll definitely answer them.
Yes, and we will definitely answer it to you. Thank you for watching this live topic discussion. I hope it was educative enough to everybody.
Hope you are very clear in our talk.
Thank you all for watching.
Yeah.
So.